Good afternoon and welcome to another Ask the Doctors on Whitewater Community Television's WGTV Channel 11, WCTV Channel 21, streaming on Facebook Live, and this program is also available on CTV3 in Connorsville. I'm Eric Marsh, Executive Director of Whitewater Community Television, surrounded by the doctors, the people who are here to answer your questions. Dr. Thomas Huth, Vice President of Medical Affairs at Reed Health. He came back. Dr. Jetmore.
Couldn't stay away, Eric. I was lost without you guys last week.
Public Health Officer, Wayne County, thank you very much. Glad to see you. Glad you're back. Hope you both have had a very good week.
Been a great week.
Good.
Same here. Good week.
We have a guest on the phone, Dr. Matthew Vale, who is the lead infectious disease doctor for Reed Health. Dr. Vale, are you with us?
Yes, I am, Eric.
Thank you very much for joining us. How are you today?
Good. Thank you.
I'm not familiar with your name, and I understand very quickly from Dr. Huth that you have not been here long. Can you give us a little bit of your background and what kind of brought you to the area?
Sure. I am an infectious disease trained physician who was practicing at a smaller hospital previously, and got the opportunity to interview and accepted to the position here at Reed at the end of February, and then started mid-March. My training was IU Medical School, and then internal medicine residency training at Methodist, and then back to the Med Center for my infectious disease fellowship.
Okay. You came at an opportune time, I would say, probably a very busy time to get started in a new place. What's it been like for you making this transition?
It's been something else. Especially early on, the amount of work and meetings and just everybody all in to make sure we were providing the correct care and protecting ourselves and hospital employees based on CDC recommendations and the literature. It was overwhelming at first. Things here, like I think in a lot of different places, as we've gotten used to the donning and doffing of the PPE, the protective equipment we wear, and have gained more knowledge about the virus. It's becoming a lot easier and more efficient to take care of patients and feel safe doing so.
I'm sure these gentlemen have some questions they'd like to ask, so I'm going to let them jump in.
Matt, good to hear you on the telephone. Thanks for being here. I don't know if it seemed this way to you, but it has to me that so much has changed in such a short period of time. You've been with us since March, which is only 2 months, but it feels like a much longer period of time than that. And I think it's just a sign of how, we're kind of always in overdrive right now. But, we've seen a lot of things change in the treatment and management of COVID-19. Can you talk a little bit about the things that have changed, what we were doing at the beginning, that we're not doing now, what are we doing now, some of the clinical protocols that we've signed on for to provide some of the novel treatments? Just go into some of that background for us.
Yes, for sure. It's been a significant amount of change from March till now, and that 2-month period. We were giving patients, with their consent and discussion of, for lack of better words, the experimental nature of it, hydroxychloroquine, better known by the brand name Plaquenil, at least for the first month of treatment, or first month of the COVID-19 outbreak. The majority of patients that we saw during that time did receive hydroxychloroquine. We also then gave other therapies such as Kaletra, which is a HIV medication, which was thought to have in vitro antiviral effects against COVID-19. Then over the course of the subsequent, after the first 2 to 3 weeks, data became available regarding the possible benefit of blocking the so-called cytokine storm that the virus generates. That's this severe inflammation of the blood vessels, which we were definitely observing like other institutions. And so, again, with patient and family consent, utilize the intravenous medication tocilizumab for the specific purpose of trying to, if you will, dampen the cytokine storm that this virus can generate in select patients who are very ill with pneumonia or pneumonitis that the virus causes. We were then fortunate enough to be made aware of the Mayo Clinic protocol for convalescent plasma, and our blood center here that works in conjunction with the Dayton Community Blood Center through this protocol and through the Dayton Community Blood Center over the last 3 to 3 weeks, maybe 4, have been able to provide patients who are interested or their families who are interested in them receiving convalescent plasma. We've been able to provide that to 6 to 7 patients at this point. Again, these are similar to the IL-6 blockade intravenous infusion. These are very sick patients who are requiring significant supplemental oxygen or on mechanical ventilation. And the convalescent plasma is donated from people who have recovered from COVID-19 infection in hopes that the antibodies that plasma contains will be of benefit in helping the person recover.
You mentioned the convalescent plasma project, and a part of that is finding donors for it. What have we done to help to feed more donors into the system to make that plasma supply available?
We've had I guess a two-pronged approach, if you will. We have reached out to patients who have tested positive through Reed Health. In addition, we've done, Reed Health has done some advertising in this area, seeking patients who had the infection, a documented infection in this case, for donation, and have been able to recruit from both sides and supply donors to allow us to continue to give this potentially, important therapy.
You mentioned a few moments ago about the severe inflammation syndrome that happens in some of the COVID patients, particularly the more severe ones, and it seems to have a high risk of fatality when the multi-organ system failure occurs. You know that there's, I'm sure you're well aware that there is attention being paid in the last few days to, what I guess is going to be considered a version of that may happen in children. What do you make of this, these reports of children who otherwise we've thought are relatively kind of resistant to the disease? What do you make of this multi-system inflammatory system problem in children?
Well, it's, as you said, Dr. Hughes, it's, something that's just come out this week. And in fact, I believe just today, this morning, the State Department of Health issued a release regarding, asking healthcare providers to be aware of this syndrome. The Lancet article that appeared earlier this week with the Italian experience, some of the kids had rashes that were quite fulminant, but it seems like it's different than what we're seeing with the very sick adults, in that it's not driven by a respiratory disease like the adult COVID-19 severe illness is, in which patients almost always have evidence of pneumonia to both the right and their left lung, with diffuse infiltrates that are very characteristic. That's not mentioned in the Lancet report, so it's hard to compare, and at this point it's a little bit hard to know what to look for in children other than fever, other symptoms of illness, and potentially rash at this point.
Okay, and my impression is that it's probably not a very common thing. Maybe it's pretty rare, but is that your impression too?
Certainly. Don't have any numbers as far as what percentage of children who have been exposed to COVID-19 would develop such a syndrome. But like you said, I believe that percentage is very low.
One last thing I wanted to ask you about was something we've noticed lately is that at least a subset of people who've had COVID-19 and have apparently recovered from a symptom standpoint continue to test positive for many weeks afterwards. What do you make of all that?
Yeah, it's interesting that continues to happen, and I think people need to realize that these people are testing positive by what's called a preliminary chain reaction study, or lab, which is a test that looks for the genetic sequence of the COVID-19 virus. It's an RNA virus, so the test is looking for RNA of the COVID-19 virus, and these tests are typically very sensitive and able to detect minute amounts of genetic material. And I believe that's what we're seeing in these patients who have fully recovered from their illness from COVID-19. They may continue to have a very small amount of virus that is detectable by these tests. But you can't say this for sure, but are unlikely to have significant amount of virus to be a potential transmission risk. But again, that is still being worked out, and we're still looking for guidance from the CDC on that point.
Okay, well, thanks a lot for talking with us today, Matt. You're a busy guy, need to get back to your real life, but it's been fun having you on the show today.
Thanks, Dr. Hughes. Appreciate it.
You're watching Ask the Doctors on Whitewater Community Television's WGTV Channel 11, WCTV Channel 20, streaming on Facebook Live. Thank you for that. Appreciate it.
My pleasure.
Dr. Jetmore, I'm hoping that you can help us out with something before we start to get to some of the questions. There's a testing site that has been up, one of the first, I think, 20 sites that the state put in. It's currently at the National Guard Armory. I understand Monday it's supposed to be moving to the Elder Bierman building. Can you provide us any updates on that, what people need to do? There was talk when Christine was here last week that people were going online. They wanted them to register. I think I heard that part of it might be going away. What can you tell us?
Yeah, Eric, the testing site was at the National Guard Armory, and it was kind of a disappointing turnout. I think after a week, we'd only tested 40 cases. I think there are a lot of reasons for that. The Armory is kind of an obscure location, and people had trouble getting online and trying to sign up for this site. So the site's been moved to Elder Beerman, and the hours will be from 7 to 7. And rather than going through all that online ahead of time, setting up an appointment, you can just show up. And if you, and the criteria for testing are very loose. If you've been around someone with COVID-19 or are a first healthcare responder, you have COVID-19 symptoms. When you consider from Indiana State testing that 45% of people who tested positive were asymptomatic, you've probably meet the criteria if you've been out of your house of being around someone with coronavirus. So I hope as many people as they can avail themselves of these services. The test is free. If you do have insurance, bring the insurance information in. But the more people I'm thinking of Wayne County now, that's my universe. Mm-hmm. The more people in Richmond and in the county itself that can be tested, the better idea we'll have of the virus within our community. So go out there, people, and get tested.
Yeah, I think the time is now. We don't know how long they're going to be able to continue this, and so many people over time have said they wanted to be tested. Now's their window of opportunity, and if they don't take advantage of it now, I'm not sure when that opportunity will be available again.
And you're right, Tom. I think if we don't utilize this, we're going to lose it. And I think there are many people out there that are anxious for a number of reasons. They were around somebody who lives with somebody that has coronavirus. Could they have contacted it? Well, so, this will alleviate a lot of anxiety. People can get an answer. And the test results will be telephoned or texted to the person within 48 hours of the testing. It may be sooner, and it'll be completely private. So there's no reason not to get tested.
They're setting up inside Elder Beerman, or is this a drive-through, walk-through thing that's happening in the parking lot?
As far as I know, Eric, I think it'll be inside the building, but I think that building has the capacity for drive-through testing. So that may be something that might come on down the line if the testing site is utilized in a good fashion. There are a lot of people showing up.
There have been a lot of questions from people about antibody testing. That's not what this is, correct?
Right.
No, this will just be the testing for the coronavirus itself.
Okay.
In the last discussion with Dr. Vale, we mentioned that we know that a lot of people are testing positive for a long time after they've had symptoms. So I think if some people are saying themselves, well, I was sick a month ago, or I had a cold 2 months ago, there's no point in getting the nasal swab now, but in actuality, we think that there could still be utility to that because some people test positive for a prolonged period. And so I think, virtually any of us can and should go in there and utilize it while that opportunity is available, regardless of whether we have symptoms now or not.
This is Ask the Doctors on WGTV, so let's get to some of your questions. Will Reed be testing people for COVID-19 antibodies?
The short answer is yes.
Okay.
The longer answer is, as we've had with kind of everything in, with testing and treatment when it comes to COVID, it'll be a ramp up. We are finalizing the ability to do the antibody testing in our own lab equipment now, and that will come online within about a week. Now, we are going to have severely limited capacity for that at the start because, like everything else, the supplies are being, prioritized hotspots around the country, and Indiana is not in general, a hotspot, and Wayne County in particular with Indiana is not a hotspot. So we foresee that we'll have some limited capacity for some period of time, but we look to ramp that up over time and make it more generally available. We're working out a policy now on who, when, and how to test, what situations make the most sense, so that we make sure that we're utilizing the test for the best circumstances at the start. So yes, we will have antibody testing. It actually will start pretty soon, but it won't be generally available for the foreseeable future.
Okay. Let's keep going. I'm looking forward to the results of the random testing that the state is doing. I'm curious to see how far and wide it has spread. Do we have any idea at this point? I think it's how far and wide maybe it's spread, but that's why you're encouraging people to go either to the Armory or to the older Beerman building
now
starting Monday.
I think they're referring to the test that the state did, the 20,000 tests. The state of Indiana, the Indiana State Department of Health, along with the Fairbanks School of Public Health, decided to find out how much this virus had penetrated the population. So they decided to test 20,000 people, 5,000 at a time. They've done the first part of that, those 4 series of tests, that first series. What they did was, Eric, they set up 68 test sites around the state, and then they chose people's names randomly from tax rolls, from motor vehicle registration rolls, and set up to mirror exactly the population of the state of Indiana. I think toward the end of the testing, they got 900 people representing minorities to try to mimic exactly the composition of the state. So people were invited to this test. Their names were drawn or chosen, however, and they were invited to come. 4,600 people came, and they had both the viral test and they had the blood antibody test, which the antibody test, of course, tells who has had the virus. So the results were 1.7% of the people that were tested had coronavirus, and 1.1% of the people had coronavirus at some point in the past. Adding those two numbers together, it tells us that 2.8% of the people in Indiana had coronavirus. Has or had coronavirus. Mm-hmm. And this number is either fills you with elation or disappointment. Dr. Huth and I were talking beforehand. It makes you happy because our mitigation efforts have been so good that only 2.8% of the population of this entire state has had coronavirus. It makes you unhappy from the standpoint that if we want to get to herd immunity, which is 70% of the population, we're 67% away. I hope we never get there. I think we can defeat this with other means other than herd immunity. I pointed out to Tom, if we went with that concept, we've got 330 million people in America, 70% is 240 million. If 240 million got infected, we'd have, figuring a 0.6% mortality, it's 1,300,000 dead people. So I'd rather defeat this disease with other means than herd immunity. They were able to extrapolate from this data the death rate for Indiana, and it was 0.6%, which seems amazingly low. It's still 6 times more serious, more deadly than the common flu that we see every winter. But when these reports initially came out in other countries, you get China was 3.5%. Some other countries have mortality rates of 6, 7, 8%. So 0.6% is an amazingly low number. I think it's because Indiana people are particularly tough, Eric, and we're able to survive this disease better than the Europeans or the Chinese, but that may not be true. One thing that came out of this, kind of a sidebar that was kind of interesting, they commented also that if you were if you were cohabiting, living with somebody that had coronavirus, you were 12 times more likely to contract the disease than somebody not in that circumstance. So I think most of this is spread by people in close contact for a prolonged period of time. But I thought the numbers that came for this were very meaningful numbers. Now they'll do that second 5,000 in early June, and then we'll have 2 time points, and we can see if the penetration into our population is stable, growing. It'll be interesting to see what those numbers are. When we come to that point, we'll give you those numbers, Eric.
Okay. We have a follow-up for Dr. Huth, I believe, on the antibody testing. How reliable is the antibody test? What criteria will you use to determine who can get these limited tests?
Well, those are great questions, and I think the reliability is something that we've talked about over time. You know, we have to realize that all of these tests are permitted by the FDA under emergency use authorizations. And what that means is that it's gone out early in the interests of being responsive to the pandemic, but has not gone through all of the testing for reliability and performance that a test would normally do. And so every antibody test, and I think there are a couple of dozen that are being developed, and there's I think 11 of them that have been given EUA by the FDA so far. They all have their own estimates of reliability, and but I think we have to take all that with a grain of salt, and really we'll have to wait for more data as they're used over time, and it gets studied to find out what the ultimate reliability is. The big problem with the antibody tests is that we still have some uncertainty about whether we could be accidentally detecting other coronavirus infections in them. So there are literally dozens of different coronaviruses. There's not just the one that we're dealing with. There are lots of others. We've all been exposed to many of these others because they make up a big proportion of the common cold viruses that go around every year. And so the question is, if I've had a near cousin coronavirus, could I accidentally test positive on an antibody test? I think that the hope is that that's not the case. We'll just have to find out what the performance data is as it's accumulated. But I think for most of the antibody tests, they've been quoting sensitivity rates in the 90s, which is a much better performance rate than the nasal swab PCR test that we do now. And so we're hoping, with a little bit of luck, that it'll actually be a very good indicator of past infection. But none of the antibody tests are going to tell you very much about current infection because it takes a long time, several weeks, for the initial antibody levels to rise, that IgM, and that only lasts a few weeks itself. And then later on, hopefully the IgG gives a longer lasting antibody level that can be detected. Now I know that, and I don't remember if you mentioned this, when the state testing that they did here in coordination with the Fairbanks School of Public Health, they did both the nasal swab test for the nucleotides of the virus, of the active replicating virus, and one of the antibody tests. I'm not sure which antibody test they did, and that can have some different performance characteristics depending on which one exactly it was.
I've heard the antibody test they used had a very, very high specificity, like 99%.
Yeah.
So that should lend a lot of weight to the data that they did
Right.
get.
You're watching Ask the Doctors on WGTV, WCTV, and streaming on Facebook Live. Let's take another question before we get into some of the numbers that we have started doing on a regular basis. So if we have another question, let's bring that one up. Has hand sanitizer been proven to kill this particular virus? I know it does not kill all bacteria and viruses, and generally not recommended for children under age 5. Should child care programs be using hand sanitizer, as it is generally not allowed?
You know, this sanitizer for children being dangerous, I think it's if the child ingests the sanitizer. So I think they can be safely used in children under supervision. There's nothing about the child's hands that's going to make them more likely to absorb this through the skin or something like that. These sanitizers, I think, correct me if I'm wrong, Tom, I think they're 60 to 70% alcohol, and that's the danger of these children ingesting it. They always smell good.
Plus, they can be flammable at that concentration.
That's another factor.
So, you know,
So there's that
those
danger.
things are probably why they're discouraged for use in child
But
centers.
I think under supervision, they would be very safe.
Yeah.
And
but, you know, I think when there have been studies done of the relative virus killing capabilities of hand sanitizers, and there are different formulations. The most common ones use alcohol with, say, soap and so forth, and probably in terms of just the sheer virus killing capabilities, they're pretty much equivalent. But what soap and water really kind of adds to the equation is you're actually washing dirt and particles away,
And there's
which
the
you're not doing
duration,
with hand
the duration
sanitizer.
as well. If you're walking down the hallway, you do this a couple times.
Right, the duration.
The sanitizer isn't as in contact with the virus as long as it would be with soap and water, so you make a good point.
So hand sanitizer is fine, but I think if you're standing in front of a hand sanitizer and a sink with soap, I would use the sink with
Go
soap
for
and
the
water.
sink.
Okay. Let's get one more question in, and then we'll go to some numbers. For businesses and other organizations opening back up, how effective is screening people's temperatures as they enter buildings to tell if they are safe to be around others?
Well,
Well-
only about 85% of people present with a fever or have it's going to play a factor. So it's going to be 85% effective. But there may be a lot of people that have coronavirus that have a normal temperature. So there is no foolproof method of screening somebody other than a coronavirus test that I'm aware of. How about you, Tom?
Right. You know, above 90% of people with coronavirus will have a fever at some point. But if I have coronavirus, I'm standing in front of you right now, the likelihood of me having a temperature at this moment is relatively low. So by itself, temperature is not very discriminatory. And we know that a lot of people can have a prolonged asymptomatic period and be shedding virus. That doesn't mean taking temperatures is worth less. It's just that it's one data point amongst others that, you know, you add things together. And if you're not doing testing, then you have to do something. And so taking a temperature, asking questions about symptoms, and even though, yes, if I don't have a temperature and I answer no to all the symptoms, that doesn't mean I'm totally safe. But for sure, if I have any of the symptoms or I have a temperature, it's probably wise to exclude me from, you know, whatever that activity is.
Sure. You know, having a temperature is significant. Even if you don't have coronavirus, you're obviously ill. You've got some sort of infective or inflammatory process going on in your body. You probably shouldn't enter the building, coronavirus or not.
Okay. Dr. Huth, over the last few weeks, you have continued to update us with the inpatient trends at Reed. I think people might be interested in what some of those are, particularly as some businesses have started opening up. People are beginning to get out more. Hopefully, we're going to have a nice, warm weekend and people will be out. So why don't you talk us through some of what you're able to provide?
So we've seen this chart before, and we are updating it frequently. This is the data. The last data point is from Wednesday. And basically what I would say is that we're in kind of a prolonged plateau. It's not, coronavirus is certainly not gone. We have typically around 40 to 50 patients in the hospital on any given day who are known or suspected to have coronavirus. I think this morning it was 11 definite positives amongst patients in the hospital. Others suspected, either having negative tests but have consistent clinical syndrome or are waiting on test. And I think it was 7 ventilator patients this morning in the COVID ICU, most of all of whom are known to have COVID. So we still have, this is way above normal, way above normal. We don't typically have more than 2 or 3 patients on the ventilator at any given time, and we'll go long periods of time without any ventilator patients. So to be for 6 weeks straight to consistently have 5, 6, 8, and at one point we were up to 16 ventilator patients during the peak week in the early part of April. 16 patients, pretty much 15, 16 patients every day that were COVID patients. That is highly, highly abnormal. We're still in an abnormal status, but we are in a plateau. Where it goes from here, I don't know. Does it go up? Does it go down? You have to consider the possibility that with things opening up and people going out and having more interactions, that we may see a bump. It's what could happen. That doesn't mean we need to shut down again. We've all got to have lives and go out, and we can't, having a life only in your house is not a way to have a life. So, and people need to work and so forth, but we've got to make sure that we're being smart about what we're doing in the community, so we're minimizing the risk of us acquiring the disease or accidentally transmitting it to others. So we have to be smart. It's not over, but we have to figure out how to live life and get back to an economically viable situation for all of us. But that is managing the COVID transmission possibilities as well as we possibly can.
Anything you want to add?
No, I concur. I mean, this is not the time to let our guard down. I think we can go back. We can emerge from seclusion here and do this safely if we're smart. Social distancing, wearing masks, hand hygiene. You've heard all these things 1,000 times, but as we emerge, and I'm anxious to get back to more normal activities, just like everyone else. But I think if we're smart, we can come out of seclusion and people can go back to work. And I think it's the safest places are outdoors. And one of the things we've got going on is we've got warm weather coming. Someone called me today and was asking about church services. You're going to have to social distance inside, but you can be, people need to think about, why not have church service outside? Somebody told me the statistic of mass outbreaks of COVID, only 0.3% of them occurred from outdoor events. The transmission of the virus is not only dependent on proximity, but also the duration of that proximity. So, and that's why restaurants, movie theaters, theater goers, that's been so problematic, because you're sitting adjacent to somebody for 2 hours or more. But, outdoor dining, we couldn't do this in February, but we can do it now. Outdoor church services. There's a lot of things we can do that are, we have to think, I hate this phrase, outside the box, but there it is. We have to think of new ways to do some of the things we did in the past.
And maybe with warm weather, sunny weather, this is an opportunity for people to kind of get out of their house and exercise, work in the yard, build more resilience, improve their physical, resilience, so that if fall and winter come and we have resurgence of disease and we have to reinstitute more distancing and stay-at-home type of activities, we need to position ourselves to be able to weather that. So to me, an opportunity while the weather's good is to improve our own health along the way.
Yeah, I think just your mental health about being outside and not staring at four walls. I think people will be rejuvenated.
Happens in the spring on a regular basis in Indiana anyway. You're watching Ask the Doctors on Whitewater Community Television's WGTV Channel 11. Dr. David Jetmore from Wayne County Health Department, Dr. Thomas Huth, Reed Health. Let's go with another question. I understand it's all speculation, but as healthcare professionals, do you think Wayne County made an impact on flattening the curve? Was the shutdown effective locally?
I think it was. I think the low numbers we saw in terms of infections per 10,000 people, in terms of deaths per 10,000 people, I think the mitigation that we did against the virus with stay-at-home orders, no unessential travel, I think it did have an effect. I mean, we were at lower rates than all the surrounding counties. We were 11 times lower than Marion County. So I think, yes, I feel good about where we're at. I think we've reached some high ground here in terms of dealing with the virus.
I think, what you can say that we can all agree that we did not have a huge spike like what was originally projected. And we can have all kinds of argument about the accuracy of projections and so forth. But what we can say is that there is an association, at least. We had strenuous mitigation efforts, and we've had a low peak. Did one cause the other? We can argue. We'll probably be arguing about that for a couple of decades.
Well, there's no way to prove that for sure, but it certainly, it would certainly seem that the one affected the other.
So what we can say is that it's not disproven that the mitigation steps were worthless. That's my view of it.
I agree.
Before we move on to the next question, Dr. Huth, I want to give you a chance, and sometimes I know you've gone through this a couple of times, but I think it bears repeating because people don't watch this program every week necessarily. Reed Health, we've heard the stories about people maybe putting off going to the hospital. Mm-hmm. You all are starting to reopen some of your outpatient work. Talk a little bit about the hospital, how people can interact with them, what they can expect when they come to your facility.
Yeah, I think certainly we've seen a lot of hesitation on people's parts to get back to their normal healthcare activities, and that's unfortunate because we've seen some scenarios that could have had better outcomes or had better course for those individuals had there been more willingness to seek care earlier, and I can go through some scenarios, but but I do know that there are lots of people who are now concerned about coming out and going to the doctor, coming to the hospital for services. Consequently, we've got our Safe Pathways to Care program that we're morphing all our activities into, which is that we essentially have two separate systems of care. I put it that way, that we've got a pathway to safely and successfully manage COVID patients through that is separate from the pathways for people who need non-COVID care. They need to have their heart disease dealt with. They need to have their hip surgery. They need to have their diabetes and blood pressure managed again. So we've got these built. We're implementing them now. We feel very good about where that is, and to the extent that they've been used, it's working very successfully. So, and we're going to continue to leverage telehealth opportunities to take care of people so that they can feel more comfortable being able to get their care in home. And so this is all being rolled out now, and so far has been very successful, and we feel very good about it. So people need to know about this. You can read about it on the READ website. Just go to the main web page, and there's a little banner at the top that says Safe Pathways to Care. We've changed our COVID-19 information page to focus on the Safe Pathways project, and there's lots of information there about the different things people can do to ensure their own safety and make sure that they get the care that they need.
Okay. Next question up. Can you please list the symptoms and phone numbers for testing and guidelines for the elderly?
I'm not sure what you mean by the symptoms. The coronavirus
Symptoms of COVID-19, is that what they?
I would assume that's what the question is asking.
If the context is the elderly, maybe the question is, is this disease kind of different in the elderly, or, what? I think for sure the elderly are more at risk from complications, from having severe disease and complications, and there are, lots of reasons for that we could postulate. I don't know that there's been enough time to really study on why the elderly are so at risk, but they are. But it probably has to do with just general changes in the immune system function and general levels of resilience and overall health having an impact on that. And there may be some other things. We see some interesting things coming up about vitamin D, whether the elderly may be relatively relatively insufficient levels of vitamin D, aren't likely to get outside very much, get exposure to the sun, and sometimes the diet may be lacking in certain vitamins and so forth. Whether vitamin D may actually have somewhat of a protective effect by improving the immune system functioning. That's been postulated. There are some other things in there that could enter into the conversation. But what I think we need to know with the elderly is that they may not be able to articulate the symptoms like a younger person would, because there could be, things interfering with their ability to really kind of understand what's happening with their symptoms and be able to articulate that. Maybe they've had stroke, or maybe there is, cognitive disturbance and so forth. So I think with the elderly, what we're a little bit more likely to see is that some of the early symptoms are more that their thinking is not as sharp as it used to be. They may not be as likely to have fever as a part of it. There's some indication that they may experience lower oxygen levels without experiencing shortness of breath early on. But I think that the typical symptoms are all there as a part of the picture that we see with the elderly. But in particular, I think if we're caring for elderly people, we just need to be aware that something doesn't seem right with grandma or grandpa, and we need to seek care earlier, or seek advice earlier about whether, what exactly is going on. And there are many possibilities, but we have to now, in today's age, consider the possibility that COVID-19 could be a part of it. And so what tends to happen is we say, well, Grandpa doesn't seem quite right today, we'll give it more time to see what's happening. I would say in today's world, what we can do is pick up the phone and call the doctor a little sooner than we might have done 6 months ago. We might have decided then to kind of wait and see what happens, but probably it's wise to pick up the phone and get advice early.
Next question. Can COVID-19 be transmitted through water? Why did the city decide to shut down the pool for the summer?
I'm not aware of COVID-19 being transmitted through water.
Well, especially not in properly sanitized pool water. They have chlorine levels and so forth that, to my knowledge, it takes a very low level of chlorine concentration to kill most viruses, and presumably also COVID-19. But I'm sure that the concern about the pools has to do with other things than the water.
Well, yes, I don't think these two questions are, I think the person's asking two separate questions. I don't think they're related. And the second part of the question was, why did the city close down the swimming pools?
The pool for the summer.
I I think the state asked that, it said that swimming pools could be opened on around Memorial Day. I thought that was too early and asked that it be delayed until June the 14th. And then the city made the decision to not open the pools at all for this summer. I think the concern about the pools was tremendous congregation of people, and it might be an outbreak event. I think it's disappointing to a lot of people, and these are very hard decisions to make. On the one hand, you're wanting people to enjoy their life and swim, and on the other hand, you're wanting to protect people from the transmission of potentially fatal disease. So I'm not sure why the city decided to just summarily shut it for the rest of the summer. I wasn't privy to those discussions, but it may have been due to the fact that the decision had to be made ahead of time to order all those pool chemicals. And I think they also may have decided that it might be a good time to do a lot of maintenance work on the pool, painting and whatever during this period of time.
I'm going to just follow up real quickly. What was your concern about the Memorial Day date that you wanted another couple of weeks?
I thought it was too soon. At the time the governor made that proclamation, the number of the infection rate and death rate seemed to be either rising, or it certainly hadn't started to fall at all. So I just wanted those 2 weeks to see where the virus was going. Other people may have thought differently. It's very hard to make these decisions in a constantly moving environment of variable things. But that was a decision I made, to delay it till June the 14th. But the city made the decision to close the pools for the summer.
Okay. We're going to we've had already, and we'll run next week on next week's In Focus, a discussion with Denise Retz, Richmond Park Superintendent. That'll be on next Thursday's In Focus. And then on the 28th of the month, we'll have a conversation with Mayor Dave Snow. So this will be a question that obviously we'll pose to him. That'll also be part of our In Focus program, which airs Thursday nights and throughout the weekends on WGTV Channel 11. We've got about 5 minutes left to go. Let's see if we can get another question in. How trustworthy are the numbers coming in now when both testing is increasing and businesses are reopening?
Well, I'm not sure what the questioner means by trustworthy. Maybe he means the significance of the numbers. I mean, the more testing you do, the more disease you're going to find. In other words, with increased testing, you can sort of artificially make the coronavirus infection rate go up just by testing more people. But so you have to look at those numbers with that particular grain of salt. But I think the reporting is as trustworthy as can be made. I mean, we report these positive cases. We're trying to report presumptive cases. These are people that have all of the symptoms of the classic symptoms of COVID-19, and yet haven't been formally tested. In the beginning, we had many patients who came in for testing. This was back in April, latter part of March. We had no testing materials when we had no treatment. These people were they didn't need hospitalization. These people were simply told to go home, for quarantine for 2 weeks, and they were never tested, and they were never counted. So that's one of the things that we're trying to do, is grab a hold of those people and count them with the antibody test that Fairbanks School of Public Health has done, and we'll capture more and more of that data as time passes. But I think if that's what the question is asking, is how trustworthy are they with the changing of testing? you have to kind of factor that level of testing in. You know, most epidemiologists say that if the positive rate is not 10% or below, you're not doing enough testing. And I think Indiana's rate right now is 16%. It's been around 20. Many of the other states, it's around 20%. So as we get more testing, we're going to find more disease.
Well, you've got the floor, and we've got probably about 2.5 minutes left to go. Why don't you go ahead and remind people about where they can get tested right now, and if you want to encourage people to do that, or at least remind them to be able to do that, why don't you provide that information again?
Sure,
I know we
sure.
started the show with it.
I'll take that time. Thank you, Eric. You can go, starting Monday, from the hours of 7 a.m. to 7 p.m., you can go down to the Elder Bierman, the old Elder Bierman store. I don't know the address, Eric, but I think everybody knows where that is. And you can have testing for free. This will be a viral test. It'll be a nasal swab. And the test results will be either someone will telephone you or send you a text on the results of that test. So I would encourage everybody that can to go down there and get tested. And the reason I say that is because, you know, 45% of the people on previous tests that we've done, just mass screening tests, have been positive but haven't had any symptoms. So you may have already had coronavirus, but it would be nice to find that out. Now, you're not going to find that out from this test. It's not an antibody test, but you can find out if you where you stand. If you have insurance information, go ahead and bring that. They'll bill your insurance company if it covers that. But if you don't, go ahead and come down and be tested free of charge. I want to encourage people to do this because when the testing site was at the Armory, only 40 tests were ever done in a week's period of time. And if we don't utilize this testing site, they'll take it away from us. So I want to keep this going.
Okay.
I think if I could just jump in and say, I think we want to make clear that we don't want more cases.
No.
But we do want to find the cases that we believe are there.
No.
We believe we're dramatically undercounting the
Yeah.
cases, and we'd like to know about every case that we can, just because that's good public health, to know what we're
Yeah.
dealing with, and so that we have the truth. But I say that because I think some people might get the impression that we're trying to manufacture cases, and that's not really it.
No,
Okay.
we
We're
just
gonna
want to
have to-
know. We just want to know the
we're
facts.
out of time.
You know, the more data
I
we
want to
have.
remind you that we'll be back next Friday, 2 o'clock. Wrap it up. He's counting me down in my ear. Check for Dr. Huth on Wednesdays on WHIO TV at 5 o'clock. I wish you well.
Thank you, Eric.